Good afternoon. Thank you so much for that very kind introduction. So I just spoke to Madam and she said, I said those nice words for you because I want you to be on time or finish earlier than that. So that's where it is. So let me call Dr. Chirag, Dr. Seema, Dr. Bhargavi, Dr. Sainath, Dr. Rajiv, and Dr. Srinivas. This panel discussion is on HER2 high. Let's move from the low to the high. And as my panelists, you're on a high. So as my panelists are taking their place, this is a disclaimer. During the course of this panel discussion, I will do some subset analysis. I will do some cross comparisons, all that you're not supposed to be doing as a person who interprets scientific literature properly. Okay, so with that disclaimer, let me start. So they've given me 45 minutes. That's very generous of the organizers. Okay, so we're moving and we're getting better over time. So we had chemotherapy, trastuzumab, pertuzumab, and then TDM1. But I think the point is on the left side, you see that the absolute numbers of patients who benefit from these incremental therapies is not huge. Most of the time, it's less than 10%. So I think it's very important to make our choices properly, choose our patients for these treatments in a very prudent fashion. So let's start with the first abstract. This is the 8.5-year median follow-up of the Affinity study, randomized patients to trastuzumab versus trastuzumab plus pertuzumab. The overall survival is what was the readout. You're not seeing any difference. That's the curve on the top. The invasive disease-free survival is the curve on the bottom. You see a very small difference, 2.6% with a hazard ratio of 0.77, but statistically significant. So let me start with Sainath. Sainath, does that all the more question the surrogacy of DFS for OS? After 8.5 years, you're still stuck.
So I think still we can't come to that hard conclusion that DFS is a surrogate marker for OS, especially when we are talking in adjuvant setting, where overall survival is our goal, the final
So you're
goal.
not very impressed with the endpoint that I'm talking about now. Is that right?
Yes.
Thanks. Seema, 57% events reached at 8.5 years. And then you've now got TDXD, you've got tucatinib, you've got margetuximab, you've got pyrotinib, you've got neratinib. Will you ever be able to show an overall survival benefit?
It is difficult to show OS benefit given the multiple lines of therapies that is available and that are effective. We have seen that even TDXD has shown a remarkable response rate of 80%. Even in the metastatic setting, after prior 1 to 2 lines of therapy, the PFS has improved by more than 4 times compared to the control arm. So to show OS benefit is difficult, but looking at this data, I don't think that pertuzumab it is advisable to use pertuzumab in adjuvant setting.
We'll come to whom we will use pertuzumab in a moment. Rajiv, are you impressed with the magnitude of benefit in terms of the invasive disease-free survival, a 23% risk reduction, 2.6% absolute difference? Is that good, modest, bad?
I think in an overall outcome, it doesn't make much of a difference in majority of the patients who receive adjuvant pertuzumab. But we still don't know who is the person who is going to really
We'll come to who will benefit in a moment, Rajiv. Dr. Bhargavi, does this impact the way you treat your patients with early breast cancer, HER2 positive?
As of now, it is no.
As of now, you're not changing anything based on what you're seeing on these updated results. So let's do some hair splitting here. Okay, the curves on the left are node positive, the curves on the right are node negative disease. Node positive, the one on the top is overall survival, 2% absolute benefit, but that's not statistically significant. You see the upper limit of confidence interval touching 1, so that's not significant. Maybe a couple of years, it might be, we don't know, as more events will accrue. The one on the bottom, 5% absolute benefit, 28% risk reduction. Seems to be reasonably okay by today's standards. But I'm more interested in what's happening on the right side of your screen, right? Node negative disease, for overall survival, there seems to be a minus 0.9%. And the upper limit of that confidence interval is 1.55, which means that some patients might actually have a 55% increased risk or a detriment. Okay, the one on the bottom, minus 1%, upper limit is 1.42, so 45% possible. Not necessarily will happen, a possible detriment. So, Chirag, would you agree with my interpretation that this is a detriment, or you would say, no, there's no benefit, that's the way we would interpret it, and we would not interpret it as a possible detriment? What is your view?
So I won't call it detrimental data, but no benefit definitely. Not detrimental because the trial was not designed statistically to show that fact in this trial.
Okay, does this make you a little nervous? No, you just say, it's all right, I don't want to look at this. I'll just take the overall picture and then move on rather than looking at the node negative population. Srinivas, would you also agree with that? And then after that, yes, Seema? Yeah. Okay, you go ahead.
So I mean, by looking at this data, when this detriment of minus 1% and the 95% CI is crossing the unity, I would like to see what were those detriment. Was it more cardiac toxicity by using pertuzumab in combination with trastuzumab that has led to the detriment? Obviously, I would be careful and I would be interested to know why that had happened in what subgroup of patients.
In knowing why that happened, we actually don't know this at this point in time, but you would agree partly at least with my interpretation that there may be a potential, maybe Sainath?
No, sir. I would still say if we are having such a wide confidence interval, there are only two possibilities. One, we are either dealing with a heterogeneous population. Two, probably for this analysis, it is underpowered. So I will not interpret that data beyond that. I would only say that it doesn't benefit.
Okay, excellent. Srinivas,
Can I raise a point? Hey,
Amit, yeah.
Too short, you can't see me.
Yes.
You couldn't, this is splitting the statistics. So that way you could say there was one more death in placebo and one more event in placebo. Look at that data. There were, if I see 38 deaths with
38 and
39 in the
Correct,
control
correct.
arm.
I agree.
So, you could argue there is one more death in among thousands of
I
patients.
entirely agree with you. That's why I said, there are many ways of interpreting this number. What is the view of the panel? So I never said that there is certainly a detriment. I said there's a possible. Right. Okay. So, Srinivas.
Yeah, so looking at the data, presently our usual subset of patients where we use dual anti-HER2 blockade is mainly node positive disease. If we see and thread out the affinity data, they still recommend dual anti-HER2 blockade even in node negative population.
We'll come to that in a moment. Right. So I think the right interpretation is that there is no benefit.
Yeah.
Right. We will not call it as a detriment, though there might be a tendency to do that. But I think Amit is right, Sainath is absolutely right. But there's a little bit of nervousness there, certainly when you look at such wide confidence intervals with 1,800 patients. So not very convincing, at least for that population. Just a point, because we are running short of time, that the benefit was similar whether you were ER positive or ER negative. So that should not be a reason to choose pertuzumab versus not. So based on this data, Seema, for your next patient who would qualify for an intervention like this, if this patient had T2 or more, what would be your adjuvant therapy if it was node positive? And what would be your adjuvant therapy if it was node negative? Based on the affinity study.
Yeah, I'm still not convinced that all node positive patients should receive pertuzumab. Node negative, definitely not. And in node positive also, in that subgroup, there is no OS benefit. And the benefit is there, but that is very minimal, 1.9%.
Just missing one.
Yeah.
Okay, Sainath?
Same, sir. I think in node positive, it's one-to-one discussion with the patient. The benefit may not be large. Node negative, definitely no.
Chirag?
So I will take half a minute more.
Please take half a minute.
Yeah. So it depends on whether you believe in PCR or not. That is first thing. And second thing is that whether you believe in changing the treatment based on PCR or not. That's another thing. I do believe. So I will give TCPH.
Okay, so you will give therapy. So the point is that we will use this therapy. There is some data that it might be beneficial in patients with node positive, but at least based on the affinity, there's no benefit in node negative. We don't believe that there's a detriment, but there's no benefit. What would be now keeping this result in mind, what would be your neoadjuvant prescription for a 4 centimeter node negative patient? Srinivas, you started talking about it, so you can now go ahead and expand.
Yeah,
we know that there's no benefit in node negative. So in the node negative, if you're using neoadjuvant, which is what all of us would do today, would that be a case for dual anti-HER2 therapy or not?
No, so couple of factors I would take into consideration based on the patient profile, and then I'll decide whether I need to give anthracycline sparing NACT or a combination of dual HER2 with TCHP combination. So, but in such patients where it is primarily a T2 disease, even though node negative, I would still prefer to give dual anti-HER2 blockade.
And the reason for that?
So basically large tumor size actually, even though it's a T2 disease.
4 centimeter.
Yeah, it's a large T2, I would consider it as.
Okay. You seem to be practicing in California, it looks like. 4 centimeters large T2. Okay, accepted. So you would use dual anti-HER2 therapy even though the affinity is showing that there's no benefit in terms of DFS and OS for this set. So essentially, are you saying that I want to reach pathological complete response and that is why I'm using this therapy? Rajiv, you're nodding vigorously. Is that the reason?
Yeah, I think that's what. So if it is, in practice, if the patient comes with node positive disease.
No, node negative.
No, I'm just talking about the affinity and how we are going to change practice. So if there's no neoadjuvant given comes to me with node positive disease, and then I will discuss dual therapy adjuvant. But if it is neoadjuvant to be planned, then everybody will, this particular patient, I will discuss dual therapy. So that my aim there is to get a PCR, so I need not change treatment at the end of the surgery.
So that is your reason, Sainath? Would that be your reason also?
No, sir.
No.
I think that is the reason why I said when there is in the node negative affinity population, when there is wide confidence interval, we can't probably use that analogy when we are trying to treat a 4 centimeter tumor in an NACT setting.
So how would you approach this
So
patient?
my approach would be in patients, either if you want an anthracycline sparing TCHP, especially if the finances are okay with the patient. If not, and there are no other contraindications, it would always be anthracycline, 4 AC followed by 4 Taxol with trastuzumab.
So if you want to do an anthracycline sparing regimen, you will do dual anti-HER2 therapy, is that?
Yes.
Yes?
Yes.
Okay,
Yes.
Chirag and Seema?
Because you always have, even if I don't use, I'm using an anthracycline and only a single HER2 you blockade, because if I know that if the patient doesn't reach a pathological complete response, you do have a drug, TDM1, in your adjuvant setting. So that is
So
the
would
reason
that
probably
rule
if I'm
also
using
apply if you
anthracycline-
just use TCH rather than TCHP, just to understand, because you might be over-treating some patients, for sure, and we know that in a node-negative population, at least in the long run, there doesn't seem to be a benefit. So would escalation be a better idea is my question.
So TCH followed by TDM, yes,
Yes.
that's also a possibility, but most of the cases which we have seen, I mean, in my practice was that in patients even who are, the percentage of patients in whom we want to avoid anthracyclines are very few. So most of them would either get TCHP, especially if the finances are not an issue, and if there is anthracycline contraindication, they can't afford Perjeta, obviously it's TCH. You are
Seema?
left without choice.
I think my take on that is...
Okay, Rajiv and then
Yeah,
Seema.
so if you believe that you're going to change your treatment based on PCR, that means you want to achieve a PCR. So,
Pardon me, I didn't get that, Rajiv.
so if you're planning to change to TDM1, if no PCR, that means your endpoint is to get a PCR at the end of neoadjuvant therapy. And the best neoadjuvant PCR would be with a dual anti-HER2 blockade. So that's how I look at it, yeah.
Okay, so we are all still driving to that PCR. All right, Seema, and then we will wind up this part quickly.
Yeah. So I would prefer to use ACTH because this is what we are doing in the routine practice also. I'm not convinced of using pertuzumab in this 4 centimeter node negative patient.
Correct. So this was, the couple of points that I put here now. And the reason, there's a nice discussion on this in the ESMO plenary if you listen to this. And Dr. Cortes, when he was asked, why do you want to do dual anti-HER2 therapy when the affinity study is actually negative for a node negative population, his explanation was this, and I'm not very convinced with this. His explanation was that if clinically your patient is node negative, based on an ultrasound of the axilla and a needle aspiration, 25% are still likely to be positive and they may benefit from the addition of another anti-HER2 agent. I don't know, I'm not very convinced. The second reason was, what our panelists are actually saying, that there is a lesser need to escalate to TDM1. Again, I'm not convinced. I'm more happy to escalate to TDM1 if somebody does not do well in the neoadjuvant setting rather than the other way around. But I won't dispute that. Let's not, continue that discussion / argument over here. My thought is that if somebody came to me with node negative disease, I will not do pertuzumab because I'm treating my patient to improve DFS and OS. I'm not treating my patient to increase pathological complete responses. You know, that's what I was discussing with Amit. After decades of pathological complete response, the pharmaceutical industry has driven this so deeply into our brain that we want to continue to achieve that, forgetting the long-term outcome that it should be DFS and OS that we should be looking at in our patients. Never mind, I respect all of your views, but this is my view on this particular subject. Okay. Then let's come to this. If you believe so much in PCR, would you stop pertuzumab after achieving a pathologically complete response? Bhargavi, let's start with you. We've said that the outcome is going to be superb. That's what I want to get to. You've gotten there. Would you stop pertuzumab and continue trastuzumab only, or, you know, some de-escalation of treatment? Is that possible? Do you do it in your practice?
Yeah, I would stop pertuzumab only, continue.
Okay, so you're de-escalating, and based on what evidence is that, Bhargavi? Doesn't matter. It doesn't matter. All of us talk to our patients about this. Never mind. Rajiv and then Chirag, do you do that in your practice, Rajiv? You were very vigorous in achieving your PCR.
Yes.
What would you do
So
after that?
If I achieve PCR, I don't continue pertuzumab. Yeah.
So they're kind of swaying away from evidence. Never mind. That's all right. And Chirag?
No, I don't. I continue.
You
pertuzumab
continue.
because
So-
we don't have sufficient data to de-escalate.
Okay. So again, you know, PCR is determined and the outcome is determined by many things. It all also depends upon where you start with. You've got a T4B N2 and that became a PCR. That PCR is very different from the PCR that you get in a 3 centimeter tumor. Okay. So one view is that if you have lots of disease to begin with, then you continue the dual anti-HER2 afterwards. If you have smaller disease to begin with, you may, we don't have evidence for that, you may cut down on the pertuzumab for reasons of cost and of course toxicity also. So I think we still don't know who needs to continue and we don't know who can stop. But our threshold to stop has always been low, isn't it? Our threshold to, our threshold to stop after a PCR has always been very high. Our threshold to escalate has always been very low. Right? So anyway, that's how things work. Okay, so this is something like Oncotype DX that's coming for HER2 positive disease. So this is called HER2 DX, right? So it's available, I believe, in Europe. It's not approved in the US, so we don't know. We go more behind what is done in the US than in Europe. And these are many things that people are looking at. You know, the ones that I've listed on the left side, they're looking at PCR to de-escalate, early response. You know, one of the ADEPT studies that we read out today looks at Ki-67 even in patients with HER2 positive disease to decide on de-escalation. PAM50, I've been moderating panel discussions for the past 15 years. I've been talking about PAM50. I've never seen it, used it in my practice. I wonder when I will ever. Tumor infiltrating lymphocytes, again, pathologist domain. FERGAIN, you know, these are studies which have looked at various ways of de-escalating, but nothing has ever reached the clinic. And we've got an Oncotype DX for HER2 positive disease now. If something like this comes, would you be happy to adopt it, Sainath?
Yes, again depends on the strength of evidence. If it's
Strength
a very
of evidence,
good,
you will ask for prospective validation in a 10,000 patient study like Oncotype DX before you use it, isn't it? And that's like your PAM50, it'll never come, I suppose. Anybody else who's got a thought on that? Because we are talking so much of escalation and de-escalation, and then at some point in time we should say, okay, this is what I'll do if my patient achieves a PCR or has TILs with a PCR, no TILs and a PCR. You know,
So-
all of these are very different, correct?
just an addendum. It's all, what happens when a clinician sits in the clinic is that you have two choices, whether you want to under-treat or over-treat.
You always want to over-treat if it's curative.
So that's what happens in a curative setting.
Spend more or spend less at the end of the day. Right. So 25 minutes, we are halfway down. So let me summarize my early disease. Dual anti-HER2 therapy post-surgery, I think there is reasonable agreement that node-positive patients should get it, node-negative patients should not get it. We don't use hormone receptor status to decide on dual anti-HER2 therapy. Dual anti-HER2 neoadjuvant, there's a lot of disagreement in the panel. Many think that even in node-negative disease, we will use dual anti-HER2 therapy. SEMA thinks not so. Who can stop pertuzumab after a PCR? We seem to be doing that without any published evidence so far at all. But I think it should be very individualized. Who can stop all therapy after a pathological complete response? I think we still don't know the answer to that question. Who should get 6 months, Sainath? We are talking of dual anti-HER2 therapy in a 3 centimeter tumor, and then on the other hand, we are talking about 6 months of anti-HER2 therapy. Who in your practice gets 6 months?
So someone who is node negative,
1.5 centimeter hormone receptor positive.
I mean node negative, T2 disease, who doesn't
negative
can't
T-
afford 1 year of trastuzumab, there probably 6 months is good enough. I think
just
we have
now
a
said we
data
will
from,
use dual anti-HER2 therapy.
I think we have a data from Tata itself saying that,
Okay.
a risk
So we
cost benefit analysis.
Agree.
It says 9 doses is as good.
So we kind of split wide end, you see. All right, never mind. That's the beauty of a panel. Adopting anti-HER2, HER2-DX and others, I think we'll need to wait because we want better validation of all of these things. Comfortable with FESGO?
So not robust data, but yeah, why not?
Why not?
Comfortable.
Srinivas, comfortable with FESGO is the subcutaneous pertuzumab, trastuzumab, right? All of us have started using that. You are absolutely comfortable.
Yeah,
Rajiv, comfortable?
Yes.
Seema, comfortable?
I have not used in any patient.
Okay.
So data says that it is equivalent.
Very good. So we seem to be using that, and I think that's fine. So that's my early disease summary. I'm not yet done. We still have advanced disease. Okay, so we'll come to advanced disease. Would you rebiopsy all patients at relapse? If somebody is HER2 negative or low, would you still treat them with first line trastuzumab, pertuzumab? Start with Bhargavi.
Yes, sir, I would consider.
You will consider. So once HER2 positive, always HER2 positive. At present, what is your second line treatment after trastuzumab, pertuzumab? Rajiv? TDM1, capecitabine, lapatinib?
Yes, TDM1.
TDM1. Would the presence of brain metastasis alter the second choice? Instead of doing TDM1, would you do capecitabine, lapatinib if somebody had brain metastasis at first progression? Seema?
No, because TDM1 is effective in brain metastasis.
TDM1 works well in the brain also, so you want change. Excellent. Would you be willing to defer radiotherapy for asymptomatic or minimally symptomatic brain metastasis, Sainath, with the present drugs that we have? I'm not giving you tucatinib TDX. I'll give it to you in 15 minutes, as of now.
No, sir. I think we should definitely address because these are aggressive cancers. And again, it's again a one-to-one discussion. Most of the time, we do
Radiation. Excellent. I do radiation. So we are in agreement there, it looks like. Excellent. So this is Destiny 03, right? This is TDXD versus TDM1. This is HER2 positive disease, not HER2 low disease. As always, 60% of patients with metastatic disease will have performance status 0, right? 50% of them have had 2 or more lines of treatment. Lovely curves, dream curve for any pharmaceutical industry. Separating early, you can drive a car in between the curves. 0.33 hazard ratio, what else do you want? You're done for the next decade. I put Cleopatra, that's the first line study in the right lower part, just for comparison that, what you get in the first line with Cleopatra seems to be smaller compared to what you get with TDXD in the second line. This is just for comparison. Some, questions. Chirag, are we curing more patients with TDXD or are we likely to cure more patients with TDXD compared to Cleopatra? Cleopatra is saying that 35% 8-year overall survival. Do you think with TDXDs and all of this, more patients will be cured?
So, metastatic disease and cured doesn't go so well
hand in
together.
hand, right?
We are
Okay.
definitely extending the survival of the patient by TDXD.
So you're saying long survival.
Yeah.
How long is long? Okay. Seema, question for you. More local therapy for oligometastatic disease. There was a lot of animated discussion among surgeons as to whether loco-regional therapy needs to be done. We've got some lovely drugs now, prolonging survival into decade probably with all of these new ones. So you think we'll go and be aggressive locally, or would you say lovely drugs, so why do you want to touch the local area?
For oligometastatic disease, we should go ahead with the local treatment.
Okay, local plus the oligomet also?
Yeah.
Plus the oligomet also. Rajiv, same with better drugs that we can modify the biology of the disease itself. You think more patients should go for loco-regional therapy and treatment of the oligometastatic areas also?
We don't have much evidence for that.
Based on the better therapies that you have. Srinivas, you also think so? Excellent.
I agree with the panel.
Agree. When would you stop? Yeah, Chirag.
Yeah, so,
And then you can take the next question also. When would you stop?
sure. So, with improving the systemic therapy, I will want to treat locally the oligoprogressive disease and continue the patient on the same treatment. Wherever
No, I'm
possible.
talking about somebody is diagnosed, you started trastuzumab, pertuzumab, and then patients responded well. There were only 3 metastases at the time of diagnosis, surgery. I'm talking about that. I'm not talking about oligoprogressive disease. I'm talking.
Oligometastasis I will treat aggressively. I will try to cure them if I can, but I will go aggressively. But I was talking about oligoprogression. If patient is
Understood.
on,
There anyway we would do surgery. Agreed, agreed. How much is interstitial lung disease a concern? We heard about numbers coming down. I put there Destiny 01, grade 3 was 10.3%, but in the latest studies with better education regarding interstitial lung disease, it seems to have significantly come down. So how much is this a concern? Does anybody in the panel have experience with using trastuzumab deruxtecan so far?
Yeah, I mean, we are
Yes,
using
yes,
in
Seema,
the,
please.
we are using in the trial setting, and we haven't seen any ILD as of
Lucky, lucky. Good. So let your luck continue and let your patient's luck also continue. So we should be aware of something like this happening and then make sure that our threshold to do a CT scan is quite low. Anybody who comes into your OPD coughing and is on the study, visit the radiologist and then come to us, right? So that's what it should be. Great. Lovely drug, second line setting, overall survival benefit now, so not much in terms of complaints. We are learning to, or rather we will learn to manage interstitial lung disease, which seems to be the only problem. We get on to Herclimb. So we always use capecitabine and lapatinib. So how did this capecitabine actually get in is something that I keep wondering all the while. Sainath, you have any thoughts on that? Is it because we wanted an oral plus oral?
Probably that must be the reason.
Because if you look at the logic, capecitabine has skin toxicity, lapatinib has skin toxicity. Capecitabine causes diarrhea, lapatinib causes diarrhea, not something that anybody would want to put together, but we've been putting it together consistently. We've been using it consistently. So any basis for this? And I've never used a full dose on a single patient so far.
Both lapatinib and capecitabine.
Yes, both lapatinib and capecitabine.
That's experience is same.
Experience is the same. Right, there's some data that capecitabine might actually get into the blood-brain barrier. There are some small series of patients, 6 patients, 8 patients, where there seems to be good response with capecitabine, so I wonder if that was the reason. Now, what is your second line after TDM1 SEMA for these patients? It should be capecitabine, lapatinib. Typically, that's what all of us would use. So, do you think that in this trial, instead of that placebo, you should have actually had lapatinib?
Yes.
Right? So very smart trial design, I would say, but we won't complain because the trial has been read out now and then, we're all gaga over tucatinib and the brain. But, if lapatinib had been there, it would have been a more fair comparison rather than placebo there. So this is the top line result for the primary analysis. This is the PFS for the intent to treat on the left, overall survival for intent to treat, PFS for patients with brain metastasis. So irrespective of which group you belong to, there is very good benefit in terms of PFS and also overall survival for patients who took tucatinib compared to the placebo arm of the study. Okay, so that's the top line. We'll quickly get into how we handle brain metastasis. So as was pointed out earlier, half of all patients would have brain metastasis at some point in time. Over time, the overall survival of patients with brain metastasis has been consistently improving. This is the TMH series, something that is very consistent with what all of us see in day-to-day practice. Remember that this is Jan 2013 to 2017, not the more recent one. I'm sure you went through because they've sent you these abstracts. Is this the profile that you would routinely see, and are these the outcomes, Rajiv, for your patients with HER2-positive disease and brain metastasis?
Yes, sir.
Yes,
With
most
the drugs
of them
we have now?
will receive.
Okay, so we all agree that this is typically what happens, because for us it's trastuzumab with or without pertuzumab, depending upon the cost. Of late, more patients take TDM1, and then it's capecitabine, lapatinib, and then we are done. We come back and start all over again, I suppose. Right? We go around in circles. Yeah.
So, Senthil, in this trial, only 2.9% patients.
It is not trial, Chirag. This is the real-world evidence of patients with brain.
But 2.9% received TDM1. In today's practice, there is a little more patients will receive TDM1.
Agreed. So that's why I pointed out the time period 2013 to 17. This is not a more recent series. intrathecal trastuzumab, something on which, Seema, I think you're the right person to talk about intrathecal trastuzumab for meningeal disease, an area which is very, very difficult to treat. Go ahead, your experience.
Yeah. So, I mean, in this analysis, 5 patients received intrathecal trastuzumab and their median PFS was 8 months, similar to the rest of the group, which shows that intrathecal trastuzumab is efficacious. And before that also we have treated many patients on intrathecal trastuzumab. 2 patients we have published the results also, which were quite encouraging. The median PFS was more than 1 year.
Correct. So something that the guidelines would not really have as one of the treatment options, but I have also used it in a couple of patients, though my beginner's luck has not been that very good. I hope the next patients will do well on intrathecal trastuzumab. I will continue to use it because that's an area which is very, very difficult for us to treat. At least they did not have any side effects that you can attribute to the trastuzumab.
We usually combine it with hydrocot 50 milligram, and we didn't see any chemical meningitis or any major side effects with intrathecal trastuzumab.
Absolutely. So at least it looks safe. That's very important. So we spoke about small molecules and response in the brain. This is, and we are taken up with tucatinib because the trial had half of all patients who had brain metastasis and half had untreated brain metastasis. And that's the reason why we're very impressed with this study. There is data here. This is with TDXT, right? You're getting 73%, 73.3% responses in the brain for patients with untreated brain metastasis. That's one study. The one on the right half of your slide, which is called the DEBRA study, again showing you a 44% response rate. So very impressive. These are patients who have untreated active brain metastasis. Now this is CNS benefit in patients with brain metastasis who went on the HER2 CLIMB study. So let's just go to the right half of your slide because we don't have much time. 45% of all of them were performance status 0. 60% of all of them had active brain metastasis. The overall response rate was 47% for tucatinib versus 20% on the placebo. Complete response was 5.5 versus 5%. Suppose I gave you tucatinib today, Rajiv. Would you avoid radiotherapy?
I think so. So if it is symptomatic and limited brain metastasis, then if you have an effective agent which will have activity on the brain, we should as much avoid radiotherapy and keep it as a reserve.
Excellent. Bhargavi, would you also avoid radiotherapy if I gave you tucatinib today?
Yes, based on the HER2 climb, I can.
Based on the HER2 climb. So let's come to the bottom of the right half of your slide. I'm just showing you some response rates with the available combinations, not necessarily tucatinib. Lapatinib, capecitabine, 20% in treated, 66% in about 40 patients who had untreated brain metastasis. TDXT, 45 to 78%. Neratinib, capecitabine, 26 to 47%. So the data has always been there. It is just that we have not looked at it, is my honest opinion. And now you have tucatinib on a huge study. Absolutely, the value of that data is much more than these small data sets that I'm showing. So is it because of the huge data set that we are saying I'm more convinced and I will use tucatinib as the drug of choice for brain metastasis? Srinivas, is that the way we will look at it?
Yeah, absolutely. So undoubtedly given a choice to avoid, because the question came because with that intention only, can we avoid RT? Yes, we can avoid RT given the penetration and the data and the cerebral control rate of these medications. So we can definitely avoid RT.
Yes. So you're saying that because of the large volumes of data, it gives you more confidence to say, I don't want to do radiotherapy in this patient. I'll get a 47% response rate. Is that right? Yes. Excellent. Sainath, you would also agree with that?
Yes, sir.
So now you're getting tucatinib. You can now tell me.
If we get tucatinib, obviously I think we should be always
yes, please.
The quality of data.
Response rate for the capecitabine is in this.
Can you speak into the mic? It's a little low.
This response rate is for the treated metastasis.
This is for the untreated one.
No. The capecitabine is for the treated.
The left side 20% is treated, the right side is untreated.
The reason tucatinib data gained the popularity was, so the PFS is almost equal to all the. So if you have untreated active metastasis, the PFS is 9.9.
9 point something, correct.
And if you take it
absolutely.
all, it's all same. So that's where the avoidance of RT can be brought in. That's
I totally agreed. Larger volumes of data, much more consistent It's a randomized study. The other numbers that I'm quoting are patient series. They're not randomized study. They're all patients that were teased out of the bigger studies in which these drugs were actually used. Yes, sir.
So I think this is a very important point for clinical practice, and I'm not sure that there is a consensus, and I'm not sure whether there are any radiation oncologists still in the audience. Yeah, Tabassum is there. So, avoiding radiotherapy is because many of these patients will have a good outcome. They will live for several years, at least some proportion, and therefore we wish to avoid the side effects of radiotherapy. But the downside would also be that, the response rate is not 100%. There is a fairly substantial proportion who will have disease progression on whatever systemic therapies we do. And in them, unless one had a hawk-eyed supervision, they will deteriorate to the extent that then, treating with anything else may also not be possible. So I want to ask you whether, there are any newer kinds of radiotherapy that will reduce the concerns about using RT in these patients. And I also want to ask the audience, how many will avoid radiotherapy and how many will give radiotherapy in this sort of a situation, because this is something of practical importance.
Point well taken. So we'll give the radiation oncologist 30 seconds each and then raise of hands.
Yeah,
30 seconds.
And apart from the response rate, it's the surveillance also which is very important. I mean, frequent clinico-radiological surveillance, that is also very important, and considering the kind of patients, at least that we see in Tata, you would not be patients would not be very reliable for surveillance, such active surveillance. And yeah, the morbidity or the side effects of whole brain radiotherapy can definitely be reduced with the help of hippocampal sparing whole brain radiotherapy or focal radiotherapy in the form of SBRT or SRS. So the patient selection, the performance status, the biology of the disease is very important to consider.
So before we go to the audience,
yeah,
I want to make one comment.
Sorry.
Whether to give radiation or not, that will also depend on the number, size and location of the metastasis.
So that's what she's saying, that it has to be individualized and many others. Yeah,
so
please
with the
go
technology available now, I really don't know why you want to avoid radiotherapy. With the technology available now, even if there are more than
they want to avoid radiation oncologist, it looks
yes,
like not
even if there are more than 5 mets, you can give focal radiation with SRS, which will not give any morbidity. It's not going to cause any bone marrow suppression. It's not going to affect your patient's longevity. And if it's some local therapy which is going to give high dose and increase the cell kill, which your tucatinib cannot do, please use that.
So, but
we'll summarize that based on what everybody is saying.
Radiotherapy is also going to fail in another 6 to 12. So once you give radiotherapy, it's not that it's not going to fail. It's also going to fail in 6 to 12 months. So you'll have a recurrence in the brain with another metastasis.
Yeah. Yes, you can.
So just add one point.
Yes.
The data was always there. But this drug is into the limelight. One of the reasons we fail to highlight is probably what they are saying, it's better tolerated. Practically, lapatinib has been a nightmare.
So
they are using it in this patient.
So I think at the end of the day, it's very smart design. Right? So you didn't take lapatinib on the other side. You dared to put in half of all patients with brain metastasis. You risked failure, but you succeeded. So now we are talking about success, right? Otherwise, we say this is the reason why it failed. Right?
Just
Sainath, and then I'll
I think until and unless we have a good quality data for lapatinib or any other drug, apart from this thing, we should take radiation.
It's the large volume of data that this study has, which makes us all convinced that this is the way we should go, and this probably is the drug of choice. Also, as rightly pointed out, the DFS seems to be, or the PFS seems to be better with this combination. So quickly, raise of hands, how many would be ready to avoid radiotherapy in asymptomatic, minimally symptomatic brain metastasis if I gave you capecitabine, tucatinib and trastuzumab today? Avoid. Hey, everybody wants to give radiotherapy. You guys are there all over the place, so don't worry. Done and dusted. Done. Oh, you want me to ask the question? So it's like trial design, it looks like. Ask the question in a different way. How many would use radiotherapy? So we are not there yet. Okay, we are not there yet. So in case you decide to use or rather avoid radiotherapy, make sure that you are looking at your patient closely. You should do a scan at 4 weeks, just like we do in lung cancer, right? Don't sit and ask them to come back after 3 months. That's not the way you do this. Ask them to come back in 4 weeks, do an MRI, keep a closer watch. And as rightly pointed out, your patient should be ready to come for follow-up, especially on drug therapy. So it's very important. We've got 4 minutes, 24 seconds to go. We'll do a rapid fire. 45-year-old, T2N1, right carcinoma breast, ER negative, HER2 positive, took ACTH radiotherapy, Herceptin completed to a year, PET CT done by my neighbor after, not me, by my neighbor, 5 months after the end of, so don't ask me why you did. 2 asymptomatic brain metastasis confirmed on MRI, no systemic disease. Sainath, let's start with you. Radiation and weight, radiation and systemic therapy, or trastuzumab, tucatinib, capecitabine?
Radiation and systemic therapy.
Radiation and systemic therapy. Okay, so I'm not too sure. Everybody, how many of you would raise your hands for radiation and systemic therapy? Okay. No tucatinib. Anyway, already we have raised our hands on that. So nobody would do radiation and weight. Radiation and weight. Okay, some people.
Maybe surgery and weight.
Surgery and weight. Lovely. Okay. Okay, good. So we are not there yet. What if there was only systemic disease and a rebiopsy shows the same phenotype? Chirag?
So,
within a year of Herceptin, so TDM1, TDXD?
So TDXD was available, definitely TDXD.
TDXD is available, TDXD, right. So if it shows HER2 1+, what would you do?
TDXD.
TDXD.
Yeah.
Not trastuzumab, pertuzumab, because earlier it was HER3 positive, HER2 positive.
No, it's just within 5 months, no?
Okay, excellent.
5 months.
Lovely. So TDXD would be the drug of choice there. What if there is a systemic relapse and 5 asymptomatic brain metastasis, all less than 3 centimeters? Seema?
TDM1. If TDXD available, then TDXD.
Okay, TDXD is available, TDXD. You're impressed with the CNS activity of TDXD also. So you will avoid radiotherapy there. So whoever radiation oncologist from TMH, Monday morning you've got some job to do. Okay, yeah, free tucatinib. You want to do tucatinib? Okay, so tucatinib, capecitabine and trastuzumab. So the question here, Nitish, is this patient has failed in 5 months of end of trastuzumab. That's another thing that it keeps getting into my brain. So if you progressed on trastuzumab, okay, panelists, would you be happy to put this patient again on trastuzumab, capecitabine and tucatinib?
I would do TDXD.
You would do TDXD. So that's a very important practical point. Though on the HER2 climb, everybody had these 2 drugs before they went on to get. In reality, if somebody is progressing on trastuzumab, which is what can happen many times.
You will never have the head-on trial of TDXD versus
I
HER2
agree.
climb.
You will not have one, at least in the near future. So in that case, you would be really hesitant to put your patient on trastuzumab, tucatinib, capecitabine for a patient who just progressed on trastuzumab. No? Nitish? TDXD, correct. That's what Seema is saying. So in a situation like that, you would jump to TDXD, not do this. Okay, so this is a comparison. Never mind, we don't have time to go to this comparison now, but this is HER2 climb on the left, Destiny on the right. HER2 climb had a poorer prognosis set of patients, 1 to 14 lines of therapy. Imagine that, right? So, if you look at Destiny Breast 01, 17 lines of therapy some patients have had. So, unbelievable numbers. So, it just goes on to prove that some of these patients can go on and on and on. Last question, fulvestrant, abemaciclib, trastuzumab, where does that come in? Chirag? So, I'm kind of trying to squeeze into somewhere, so that's where I put this.
Sorry, what's the question?
Fulvestrant, abemaciclib and trastuzumab. Monarch HER improved PFS in a phase 2 study. Does that fall anywhere in your algorithm?
Yeah, so if the patient is treated with trastuzumab-based therapy in the first line, TDM1 in the second line, and maybe
capecitabine, dapacitinib in third line.
And if the patient is still eligible for a hormone, symptomatically, why not?
Correct. So now I've had a couple of patients and kind of decent response going on.
I just want to say that the clinical phenotype of some HER2 positive patients is actually that of luminal. And often they have strong receptor positivity. For some reason, they also have HER2 positivity. And the clinical phenotype, you can see the disease is behaving like a luminal disease.
Absolutely.
In those patients, I think it may be an opportunity to use.
I think we will certainly interpose it somewhere in between, between those, 2 big-time anti-HER2 therapies, I suppose. And we've done it in practice, and it works, right? These are the future studies. So, quick summary of HER2 positive MBC. Don't throw me out. 30 seconds. Once HER2, always HER2 positive, right? Trastuzumab, pertuzumab, we'll continue as the first line till TDXD reaches there. Wherever possible, second line TDXD. ILD is not a major problem if we keep a close watch on it. Are we comfortable not radiating the brain mets? Not yet. Tucatinib, trastuzumab, capecitabine or TDXD for active brain metastasis, it looks like tucatinib seems to be the way to go, but TDXD also has excellent activity. Can we stop anti-HER2 maintenance? We didn't answer that question. I don't think that question has a good answer as of now. We are splitting hairs over cutting down on therapy in the adjuvant setting. I don't think we'll stop therapy in the metastatic setting. TDX likely to move to the first line, probably over time. And this is the problem, cost, right? So the oncologist clinic has become another area where you're starting from the right to left, not the left to the right. Thanks so much.